I'm going to share the PowerPoint. Give me 1 sec to do that. And then I will get started with the lecture. So I took a look at, just to remind myself of what I gave to you guys in terms of pre-recorded lectures for Unit 6. And I did go through the various types of blood cells, erythrocytes, leukocytes, and thrombocytes in a recorded lecture. So I'm obviously not going to cover that today since you already have that. And I also did blood clotting, the entire process of hemostasis and formation of a blood clot. So I will be skipping that section too. So really, we're just going to start with like a quick overview of blood, some of the blood disorders, and then our main focus today will be on the immune system, since that's what we don't have the pre-recorded lectures for. All right, so starting with the blood study outline that I provided for you in the first Unit 6 section on D2L, it begins with blood composition and functions. So you can see on the slide right here that there's 2 main components of blood. There's plasma, which if you look at this test tube that's been centrifuged, the plasma is shown at the top and formed elements are shown at the bottom. Plasma is the liquid portion of blood. And the formed elements are the blood cells that are found basically circulating through the blood plasma. So going down on your study outline, you can see the physical characteristics of blood. They're all filled in for you. And then below that are the 3 main functions of blood, which are transport. So that would be like transportation of gases like oxygen and carbon dioxide, also of nutrients like glucose, hormones, and also waste products. Another function for blood is regulation, and it helps to regulate a couple of things. It helps, first of all, to maintain body temperature, also pH, and water content of cells. And then protection. So it does 2 main things for protection. First of all, it prevents blood loss because of the clotting that occurs, and prevents infection. Okay, so taking a little closer look at, whoops, I went too far. Looking at blood plasma a little bit closer, it has, again, you can see it here in the test tube, it has a slightly yellowish color. It is mostly water. It's about 90% water. The other 10% are solutes that are found within the fluid part. And in terms of what those solutes are, there's 3 main things which are listed in your outline. You have electrolytes, which are various ions. They're listed there, like sodium, potassium, calcium. Also plasma proteins. And there's 3 main ones that are listed in your study outline. There's albumin, globulin, and fibrinogen. And they're actually listed in order of most abundant to least abundant. So you have the most of the first one, albumin, which helps to maintain water balance and blood volume. So that makes up about 60% of all the plasma proteins in blood. And the second one is globulin, and that is part of antibodies and carrier. They serve as carrier proteins just to transport various things in blood. And fibrinogen, that forms the fibrin threads, which are a main part of a blood clot. So fibrinogen is involved in formation of a blood clot. Okay, then nutrients are also found kind of floating around in the blood plasma. And these nutrients are things like glucose and amino acids that have been absorbed from the digestive tract after you've eaten food. Respiratory gases, we've talked about that the blood transports oxygen and carbon dioxide, and then also hormones. So that's the plasma component of blood. And then, and that is a little bit more than half. You can see on here, it's about 55% of your blood is blood plasma. The other 45% are the formed elements, which are the blood cells. And these are erythrocytes, leukocytes, and platelets. So this is the section that I do have a recorded lecture for. So I am going to skip. If you guys are looking at the study outline, I'm skipping page 3, where it goes through all the characteristics of erythrocytes, because you have the lecture on that already. And also the hematocrit section. So now I'm on page 4, and I'm going to pick up with erythropoiesis, because I don't really talk about that too much in the recorded lecture. So the term erythropoiesis means production of erythrocytes. Erythrocytes are the red blood cells. And essentially your body just wants to maintain a constant, steady amount of erythrocytes in the blood, because they do serve an important function. They carry oxygen in the blood. So you want to make sure that you have enough, but not too much at the same time. If you have too few erythrocytes, that leads to hypoxia, which is a decrease in oxygen. So the main function of red blood cells is to carry oxygen. If you don't have enough of them, then they're not going to deliver enough oxygen to your tissues. On the other hand, though, if you have too many erythrocytes, then blood becomes too viscous. And the term viscous or viscosity refers to the thickness of blood. If you have too many erythrocytes, then blood is actually going to become too thick, and it can kind of clog up some of the smaller blood vessels in your body. Okay, so in somebody who is relatively healthy, not suffering from any kind of diseases, the rate at which erythrocytes are produced is about 2 million per second. So it's a lot. However, that is replacing erythrocytes as they die. So red blood cells do have a certain lifespan, and they do die, and they stop functioning, and they have to be replaced. All right. So moving down in the outline, the term reticulocyte count, that actually can give you a measure of the rate of erythropoiesis, because reticulocytes are formed in the process of forming erythrocytes. It's like a precursor to an erythrocyte. So normal reticulocyte count, it's going to be about 1 to 2% of all the erythrocytes that are in your blood, that are in circulation. Okay, so the way that erythropoiesis is regulated is mainly through hormones. And there is a hormone that is responsible for this. Here we go. And that is called erythropoietin. That's a hormone produced by the kidneys that stimulates this process. It stimulates erythropoiesis. So normally there is a small amount of erythropoietin that is just circulating through the blood, and it maintains a constant rate of red blood cell production. But if your body detects any decrease in blood oxygen levels, that could be an indication that there are not enough erythrocytes. So that triggers the increased production of erythropoietin. And let's just talk really quickly about what could cause a drop in oxygen levels in blood. There's a couple different things. It doesn't necessarily have to be just that you don't have enough red blood cells, although that could definitely be one of the causes, and that is the first one that's listed. If you have a reduced amount of red blood cells, that could be because of an injury and you're bleeding out, so you're hemorrhaging. Or if there is excessive red blood cell destruction in the body for some reason. There are certain diseases where that does happen. And that's one of the causes. Another one is if there's insufficient hemoglobin, and that could just be because of an iron deficiency, for example. And another reason why you might have reduced oxygen in the blood is if there is just reduced availability of oxygen in your environment. So there's just not as much oxygen in your environment as normal. And that can happen for a couple of reasons. If you travel to an area where, for instance, you're at like a higher altitude, there isn't as much oxygen at higher altitudes as there is at sea level. Or it could be due to disease. If you're suffering from some type of respiratory disease that prevents a normal level of oxygen from reaching the bloodstream. And one other thing that is involved in the regulation of erythropoiesis is just having the right materials that you need to make new erythrocytes. There are certain dietary requirements. So you have to have certain things in your diet in order to have enough of them to be able to make new red blood cells. And those are things like nutrients, like amino acids and lipids and carbohydrates. All of those things are needed for making any new cell, including erythrocytes. Also, vitamin B12 and folic acid, they are needed for making new DNA. And iron. Iron is definitely needed because that is a main component of hemoglobin. And hemoglobin is one of the main things that is found in red blood cells. You have tons of hemoglobin molecules within red blood cells. So that is very important too. Okay, so the normal lifespan for red blood cells is about 100 to 120 days. And once they reach the end of their lifespan, they stop functioning properly, and these old red blood cells get removed from circulation by the spleen and the liver, and then they are destroyed. They're broken down by phagocytes that are found in those two organs. And when they're broken down, you have these various components that they're broken down into, and a lot of those things can be reused, recycled to make new cells. Remember, again, one of the main components of red blood cells is hemoglobin. So that gets broken down into heme and globin. Heme is the iron group and globin is the protein. So then you can further break those things down. The globin, which is a protein, can be broken down into individual amino acids. And those can just be reused to make new proteins. And then from the heme, when that gets broken down, you get iron. That's one thing. And iron gets transferred to these proteins that actually can store the iron. They're called ferritin and hemosiderin. So these proteins just store that iron until you need it to make new hemoglobin molecules if you're making new red blood cells again. Okay, the rest of the heme group, not the iron part, but the rest of it is converted into bilirubin. And we've talked about that a couple of times. That's that yellowish pigment that it's in the liver and it gets transferred into bile, which then gets secreted into the intestines if your body is digesting fat. All right, so last thing here with the erythrocytes is erythrocyte disorders. One of the main ones is anemia, which is a condition where the ability of blood to carry oxygen is for some reason reduced. And there's various causes of this. It could be just due to blood loss. So you're losing erythrocytes. You don't have enough red blood cells, or there are too many red blood cells that are being destroyed. So anemia due to blood loss is called hemorrhagic anemia. That is the excessive loss of red blood cells due to bleeding. Okay, so you're bleeding and you're losing blood, and that means you're losing erythrocytes or red blood cells at the same time. And that bleeding there could be one of two causes. It could be acute, which is very rapid blood loss, which would happen with like a gunshot wound or a stab wound, or it could be chronic bleeding, which is a very slow bleed that you may not even realize you have. So it's very small, but it's persistent, like it's continuous blood loss. And a good example of that would be a bleeding ulcer in your stomach. You don't realize necessarily that you have it, and it's not dramatic blood loss all at once, but it's slowly happening. All right, the next cause is anemia due to either decreased red blood cell production or decreased hemoglobin production. So there's a couple types of anemia that kind of fall under this category. Iron deficiency anemia is when there's reduced availability of iron in the blood, which means there's not enough hemoglobin production. Pernicious anemia is when there's a lack of intrinsic factor, which prevents vitamin B12 absorption in the stomach. And remember that vitamin B12 is needed to make red blood cells. So if you're not able to absorb that vitamin, it's going to prevent the normal production of red blood cells. There's also aplastic anemia, which is destruction or damage to red bone marrow. And remember, it's in red bone marrow where red blood cells are produced. So if red bone marrow is damaged or destroyed, that's going to impair the production of new red blood cells. And then renal anemia. That's where there's a lack or a decrease of erythropoietin. Remember, we talked about that's the hormone released by the kidneys that triggers the production of red blood cells. So if there's a lack of production of erythropoietin, that's going to impair the production of new red blood cells. Okay, and then the last cause is anemia due to just the fact that there's too many red blood cells that are being destroyed by the body. And that's called hemolytic anemia. That's excessive loss of red blood cells due to hemolysis. In lab just this week, I talked about hemolysis. Lysis means to burst or to rupture. Heme refers to blood. So it's basically when red blood cells are destroyed and they rupture, they burst. So there's two types of anemias that kind of fall under that hemolytic anemia category. There's a group of anemia disorders that are called thalassemias. And that's a type of disorder where one of the globin chains, remember globin is a component of hemoglobin. So one of the globin chains is either absent or abnormal. And that makes the erythrocytes very fragile. So they can be damaged very easily. Or they're just deficient in hemoglobin. And sickle cell anemia is similar to that. Again, there's an abnormal globin chain, the protein chain in hemoglobin. And it has the same effect. It causes red blood cells to be sickle shaped or crescent shaped. and they are damaged and they rupture very easily because of that. So all those disorders are basically not having enough red blood cells or hemoglobin. But there is a disorder that's where you have too much. That's called polycythemia. And this is an abnormal increase in the amount of erythrocytes. And a couple minutes ago, we talked about why that could be dangerous, because that increases blood viscosity. And that could clog small blood vessels like capillaries. So that could be dangerous too. All right, so now we're on to the leukocytes. And again, remember, I have the recorded lecture on all the characteristics and the types of leukocytes. So I'm going to skip over page 7 that goes over all of that. And page 8. And we'll pick up on page 9 with the leukocyte disorders. So let me get there in the PowerPoint. Here's the leukocytes. Actually, let me show you guys really quickly. If you're looking at under the microscope, if you're looking at a blood smear, these, the ones that are most common that you're seeing on this picture, like the smaller kind of reddish, pinkish looking circles, these are all red blood cells. The large purple circles are leukocytes. These are white blood cells. And there's only one tiny little purple dot right there. That is a thrombocyte, which is a platelet. All right, so leukocyte disorders, there's really just one group of disorders that you need to be familiar with, and that is leukemia. There's various types of leukemia. So just know that it's a group of cancerous conditions involving the overproduction of abnormal leukocytes. So you're actually making a lot of leukocytes, but they are abnormal. And that means that they are not performing the usual function of leukocytes. So red bone marrow becomes filled with these cancerous, non-functioning leukocytes. And then that inhibits the production of normal blood cells. It inhibits the production of normal leukocytes and even erythrocytes and thrombocytes. These cancerous leukocytes, because they're not functioning properly, they're not able to properly defend the body against infection and diseases. So the person is very prone to developing infections. Okay, and then the last type of blood cell are the thrombocytes, which we call platelets. And in the recorded lecture, I do discuss just there's not a whole lot here, but basic characteristics of platelets. They are involved in blood clotting, which is the next section here. And it's called hemostasis. That is basically stopping bleeding. And remember, I have a whole recorded lecture on this entire section for hemostasis. So if you have your outline in front of you, you're going to skip over that whole section. Make sure that you do listen to the pre-recorded lecture so you get all of that information. I cover all of that all the way up through page, or at least halfway through page 13. So on page 13 is where I'm going to start up again with the parts that are not on that recorded lecture. So let me skip to that on here. And we'll talk about disorders of hemostasis, disorders related to blood clotting. That's on page 13, in the middle of page 13. Okay, so there's a couple that are listed here. The main one is hemophilia. And again, it's not just a single disorder, it's a group of disorders that are related to bleeding. And it results from a deficiency of various clotting factors. For symptoms, basically severe and prolonged bleeding, even with like a very minor injury, you can have severe blood loss that just doesn't stop. And also often pain in joints, because a lot of times there's an internal injury that you don't even realize, and blood is being released into the joint capsules, like into the spaces of your joints, and it causes pain. And the other group of disorders here are thromboembolic disorders. These are related to blood clots that have formed. A thrombus is a clot that develops within an unbroken, undamaged blood vessel. And that can block blood flow and can lead to tissue death. If a tissue is not getting the blood that it needs, and mainly it's the things that blood is carrying that it needs, like oxygen and nutrients, then it is going to die at a certain point. And an embolus is a traveling blood clot that forms when a thrombus breaks off from its original location. You can see that in these pictures that are here on the PowerPoint. You can see the original thrombus or blood clot and the embolus that breaks off. Okay, so anticoagulant drugs can be used to prevent unnecessary blood clotting or undesirable blood clotting. And I've given you a couple examples of these: aspirin at low doses, more, I guess, ones that wouldn't be not over the counter. These would be prescribed by a doctor. It would be something like heparin or warfarin. Okay, I'm going to do a little bit on the blood groups, but keep in mind, if you did have lab already, then you know this. We talk a whole lot about this, and I give you all this information in lab. So anything that I'm skipping over here, for those of you that have not had lab yet, you will get this in your lab when I see you next week on Tuesday. But I do want to do just a little bit of this. Just to introduce you to the blood groups, and then talk about one disorder that can happen. So blood is typed, like we have the various blood types for humans based on the presence or absence of two different antigens that may or may not be found on your erythrocytes, your red blood cells. These are antigen A and antigen B. So it's all based on, your blood type is all based on whether you have these antigens, one or both, or whether you don't have them at all. So for blood type A, the individual does have the A antigen. Blood type B, the individual has the B antigen. For blood type AB, the individual has both A and B antigens. And blood type O, that's, you can think of it rather than an O, like a third letter being added here. Think about it as like a 0. This individual has no antigens. They don't have A or B. Okay, blood plasma. So those are on your red blood cells. And then blood plasma often contains antibodies. And these antibodies would react and actually attack either the A or the B antigens if they are mixed. So there is an anti-A antibody that would attack the A antigen. There's an anti-B antibody that would attack the B antigen. So you would never, ever want to have those particular antibodies in your blood plasma, which would have that negative reaction with your own antigens. However, you will have the opposite antibody. So for example, if you're blood type A, which means that you have the A antigen on your red blood cells, it means that you for sure wouldn't have the anti-A antibody in your blood, because that would attack. They don't go together. but you will have the anti-B antibody in your blood. Okay. So the other thing I want to mention is a third antigen that may be on red blood cells, and it's called the Rh factor. The Rh factor is simply another antigen that may also be present on the surface of the erythrocytes. And unlike with the A and the B antibodies, where you just have the opposite one from the antigen that you have, there are not normally any anti-Rh antibodies in anybody's blood. Even if you're Rh negative, you are not going to have anti-Rh antibodies in your blood. That does not normally happen. Okay, I am going to go over, I'm going to skip the transfusion reactions because we do talk about that in lab, and filling out the tables, we do that in lab too. But I'm going to skip to the very last thing on this outline. It's the very last section called hemolytic disease of the newborn. This was a really big issue, like back earlier in the 1900s, until they came up with a way to prevent this from happening. So basically, remember I said nobody is born with anti-Rh antibodies in their blood. No one will normally have these antibodies in their blood. If, and this shouldn't happen, but if an Rh negative person, that means that they don't have the Rh antigen in their blood. If they receive Rh positive blood, they're going to make anti-Rh antibodies against that foreign antigen. So they're going to see this antigen, this Rh antigen that is not present in their blood because they're Rh negative, and they're going to respond to it as if it's this foreign substance. They're going to make antibodies against it. So at that point, it takes a while to make those antibodies. Nothing bad is going to happen at that time, fortunately. But now that person has these antibodies in their blood. So if they are ever given Rh positive blood for a second time, now they have those antibodies already present in their bloodstream that can launch an immediate attack against that new donor blood that has the Rh antigen in it. And that is going to cause a transfusion reaction. It's going to be bad. It can be fatal if it's a large amount of blood that was given to the person. So all of that is written in your outline. I just wanted to give you a further explanation. This can happen between a mother and her baby if a mother is Rh negative and the baby is Rh positive. So normally there's no direct contact between maternal blood and fetal blood, but during childbirth, when the placenta detaches, there could be a little bit of mixing. And if that does happen, then the mother could be exposed to the baby's blood and to the Rh antigen that's in the baby's blood. So if she is exposed to that, then remember, she is going to make antibodies against that foreign antigen because it's an antigen that is not present in her blood since she's Rh negative. So if that happens, she's going to make these, as a result of that, she's going to make these anti-Rh antibodies. So nothing happens right away. The baby is fine, she is fine, but now she has these anti-Rh antibodies in her blood, and that is not normal. So the real issue can happen if the mother gets pregnant again. Antibodies from mother's blood, from the maternal blood, can cross the placenta and go into fetal blood. So if remember, these are anti-Rh antibodies, they attack the Rh antigen. If the fetus is Rh negative, nothing happens because there is no Rh antigen to be attacked by the antibodies. But if the fetus is Rh positive, then those antibodies from the mother will attack the Rh antigen in the fetal blood, and that will cause hemolysis. Remember, the term hemolysis means basically blood cells are rupturing, they're bursting, and that is fatal. So that used to be an issue until we developed a shot that's called the RhoGAM shot, which is given to all Rh negative women who get pregnant. And that actually prevents the production of those anti-Rh antibodies. Okay, so that is it for the blood outline. If you guys have been following along with the outline. So now I'm going to go to the immune system outline. And let me pull it up. I have the PowerPoint up. I just want to pull up the outline so I can go through everything that you don't have the information for already provided. Okay. All right. So in terms of just like what the immune system does, what immunity is, it basically is present to protect your body from infections, from diseases, by removing and destroying bacteria, viruses, toxins, basically anything that's seen as foreign that doesn't belong in the body that could potentially cause harm. You're trying to block them from getting into the body, or if they do get into the body, then you're trying to destroy those things. There are 2 defense systems that provide immunity, and they're on this PowerPoint: innate defenses and adaptive defenses. So the innate defenses are just a couple characteristics about them. They're present at birth. They respond immediately. They last throughout a lifetime. They are generalized responses, not targeted to a specific thing. It's a general response against anything. It could be a cell, it could be bacteria, it could be a virus, against anything that tries to penetrate the body. This is different from adaptive or specific defenses, because now some characteristics for these develop with exposure to foreign materials. So you're not born with these defenses. The response takes longer. It provides immunological memory. We'll talk about that a little bit more later. And it identifies and targets specific foreign invaders. Okay. So you have some terminology in your outline. Let me see, it looks like they're all defined for you. So I'm not going to bother just reading that off because you have that provided in your outline. But these are terms that you will see over and over again as you go through the outline: self versus non-self, antigens and antigen recognition, cytokines, autoimmunity, allergy, hypersensitivity. We actually don't talk about that a whole lot, but it's worth just understanding what causes an allergy or a hypersensitivity reaction. So we're going to start with the innate defenses. These are also called the non-specific defenses. And then we'll get into adaptive immunity at the end. So remember, the innate defenses these are things that you're born with, and they just defend against like anything that's trying to get into your body. There are basically like a first line of defense. It's like the first thing that anything coming up to your body would encounter. Second line of defense is once it actually penetrates the body, there are more cells and chemicals that are within your body that can protect it. So the first line of defense are mechanical and chemical barriers, basically on your body's surface. The mechanical barriers are your skin. So these are like, they're physically preventing things from entering the body. So it's your skin, which is many layers of tightly packed cells, mucous membranes, the hairs that line the openings into your body, like nose hairs, basically. Mechanical flushing also through any of the openings of the body, like urination, vomiting, salivation, even tear production. And then there are also chemical barriers. These are chemicals that can destroy bacteria or prevent the growth of bacteria on the skin surface. So acids, there are actually acids that are released on your skin surface, and acid in the stomach. If something were to penetrate, like get into the digestive tract, acid is released by the stomach that could potentially kill whatever that foreign thing was. Digestive enzymes also in the digestive tract. And lysozyme, that's an antibacterial enzyme found in a lot of body fluids like tears, saliva. So if something were to penetrate the body, there is a second line of defense inside the body. And that would be like the various cells and chemicals that it would encounter. Let me just skip here. So these were the mechanical and chemical barriers. Here are the cells and chemicals that you have within the body. First of all, there's a group of proteins called antimicrobial proteins. They stop the growth of bacteria in body fluids. There's interferon. That's a protein produced by a cell that's been infected with a virus. And basically what it does is it travels to surrounding cells and stops the virus from replicating any further. Complements, these are a group of inactive plasma proteins that normally are circulating in blood. And when they get activated, it usually occurs after antibodies bind to the foreign invader, whatever that might be, the invading microorganism. And then the complement binds to the antibody. So the antibody, it attaches itself to that foreign invader. And then the complement comes in and attaches to both of those things. That's called complement fixation. And when that happens, these proteins have several functions. They, first of all, can enhance inflammation. And secondly, they can cause cell lysis of that foreign invader. And remember, again, lysis means to rupture or to burst. So essentially, it's destroying that foreign invader. Okay. Inflammation is a defensive response of the body to any kind of tissue damage. It could be a burn, it could be a wound on the skin surface, it could be an infection. So there's some main signs and symptoms of inflammation that you typically see: redness due to increased blood flow in the area, heat, that's also due to increased blood flow, because blood actually is a slightly higher temperature than normal body temperature. So where you send more blood to an area, that area gets a little bit warmer. Swelling is due to fluid accumulation, fluid just kind of leaking out of blood vessels. And pain is due to that swelling, because swelling puts pressure on the surrounding tissues. So you have in your outline several of the inflammatory chemicals. The main one that you guys need to know is histamine. Definitely know that that's associated with inflammation. So with inflammation, you have a process called phagocyte mobilization. And basically that just means that you have an increased number of phagocytes that are able to reach the damaged area because of vasodilation. When blood vessels dilate, it increases blood flow and it allows more phagocytes to get into that area. And then they can kind of squeeze out and go off to the area of tissue damage. Okay, remember that phagocytes are specialized cells that perform phagocytosis, which is pretty much surrounding and ingesting and destroying microbes, microorganisms, anything that doesn't belong in the body. So 5 stages of phagocytosis are shown here on this picture. They're very simple. You first have chemotaxis, which is when phagocytes are chemically attracted to a site of damage. Then adherence is when they attach to the microbe. Ingestion is when the plasma membrane of the phagocyte kind of extends projections and it surrounds the microbe. You can see that happening right here. And then that plasma membrane totally surrounds that microbe and it pinches off and brings that inside of the phagocyte. These phagocytes are really large. Digestion is when digestive enzymes are used to break down that microbe. And then what results is killing of it. These chemicals quickly kill most types of microbes. All right, there's another, in addition to phagocytes, there's another group of cells that have kind of a cool name called natural killer cells. And these are a group of lymphocytes. Remember, those are white blood cells. And their function is to attack and kill cells that are seen as foreign, not belonging in the body. And they cause cytolysis. So they cause the cell to lyse, to rupture. Okay, and then a fever is the last type of non-specific defense. You guys know what a fever is. It's when you have a abnormally high body temperature and basically caused by pyrogens, which are chemicals that raise body temperature. So the functions of a fever are, first of all, to inhibit the growth of bacteria. Bacteria don't grow very well when your body temperature gets any hotter than your normal temperature. And helps to speed up body reactions that aid in repair. Okay, and now we're on to the adaptive immunity, which is the type that's just a little more complicated. So I'm going to spend a little more time on this. Remember, adaptive immunity is the type that you're not born with. It has specificity, which means that it recognizes and is designed to attack specific invaders, specific foreign invaders, or specific pathogens. It is systemic, so the response is widespread. It's not just confined to the initial infection site. It occurs like throughout the body. And it has memory, which means that after an initial exposure, it will recognize and protect against the previously encountered pathogen. So the more variety of pathogens that you are exposed to, the more you're actually building up your immune system, because then you have the capability of recognizing all those pathogens at a later time and properly defending against them. So adaptive immunity develops as a result of exposure to antigens, which are, in this case, they're foreign antigens. They're non-self, so not cells that belong to you, but they're non-self cells. And these will trigger an immune response. So let's talk a little bit about the lymphocytes, because these are the cells that are involved with adaptive immunity. So the lymphocytes are the B cells and the T cells. Their origin is in red bone marrow. That's where they're made. That's where all blood cells are made. Maturation, so where they, after they're made, where do they go to mature and develop? Well, the T cells go to the thymus. And actually, you can see that here if you look at the picture on the PowerPoint. T cells go to the thymus. B cells will remain in red bone marrow, and they'll just mature there. That's where they're made, and that's where they stay for now. Then they're going to travel into the various lymphoid organs, which are part of the lymphatic system, which we talked about all the way back in Unit 1. Once they are mature, these B and T cells are going to move into the secondary lymphoid organs, which are things like lymph nodes, the spleen, the tonsils. There are other lymphocytes that will also just continuously circulate through the body. Okay, so that's the lymphocytes. These will become activated if its antigen receptors bind to an antigen. When and if that happens, these activated lymphocytes will then start to multiply like crazy. They'll start to make more and more and more lymphocytes, and they will start to differentiate. So they'll become different types of cells. They'll either become memory cells or effector cells that actually perform a function. So we will talk about that specifically with the T cells and the B cells in just a minute. When they do become activated, what happens? So within adaptive immunity, there's two types. There's cellular immunity and humoral immunity, which involves antibodies. We're going to do cellular immunity first, though. That involves cells. This involves only the T lymphocytes, and it is effective against any kind of intracellular pathogen. So that would be a pathogen that comes in and it invades a cell. It takes over a host cell. So a virus would do that. Also cancer. So that's what the T cells are most effective against. Once the T cells bind to a foreign antigen, they become activated. And once they are activated, we just talked about this. As soon as a lymphocyte is activated, it starts to multiply and then differentiate into effector cells and memory cells. So in this case, the T cells will become 4 different types of cells. They could become helper T cells, which increase the intensity of the immune response. They could become cytotoxic T cells, which directly attack and kill other cells. Or regulatory T cells, which reduce the intensity of an immune response. And finally, they can become memory T cells. And these will exist in the body for years and allow you to respond very quickly and effectively if you ever encounter that same antigen, that same foreign invader at a later time. So that provides memory for your body. And then the other type is humoral immunity. This involves the B cells, and it's effective against extracellular pathogens. And this would be things like bacteria, a fungus, a parasite. So again, just like the T cells, once these B cells are activated, they start multiplying, they make more and more and more, and then they differentiate. And in this case, they could only become one of two types of cells rather than for the T cells, there were 4 different choices. Here, they will either become plasma cells, and those plasma cells secrete antibodies, or they will become memory B cells. And these do the exact same thing that we said for the memory T cells. They exist in the body for years, and they allow your body to respond effectively if you ever encounter that same pathogen ever again. Okay, so that actually, not quite. I'm skipping the antibody part because I have a recorded lecture for that. It's short, it's a short section, but I go over the different types of antibodies and what they are effective against, like what they do, what their function is. Let me go all the way down to the 4 ways to become immune, and then the 2 like immunity imbalance things, all the way at the end of your outline. All right, here we go. So, whoops. All right, here's the right slide. So different ways to become immune. There's active immunity and passive immunity. Active immunity occurs when B cells encounter antigens and then make antibodies against them. And at the same time, they make memory B cells, which are going to stay in your body and recognize that antigen if you ever see it again. So naturally acquired active immunity is when you're exposed to an antigen, you might get sick from it, but then your body produces B or T cells, memory B or T cells, depending on the type of antigen. So now you have immunity against that particular thing. Artificially acquired active immunity is when antigens are introduced to the body through a vaccination. So that's how vaccinations work. They trigger an immune response. They cause your body to produce antibodies. Passive immunity occurs when already made antibodies are introduced into your body. Okay, so there's naturally acquired passive immunity. This is when antibodies are passed from mother to a fetus across the placenta, or from a mother to her baby during breastfeeding. Those are a couple of ways that a mother can provide natural immunity to her child. And then there's artificially acquired passive immunity, which is where you can get an injection of antibodies from somebody who is already immune to a certain thing. And that would provide some immunity to you if you receive those antibodies. Okay, so last thing here is some of the homeostatic imbalances of immunity. Really just 2 main categories here that you should be familiar with: immunodeficiency and autoimmune diseases. So with any kind of immunodeficiency, it's an acquired condition that causes immune cells or phagocytes or complements to just behave in an abnormal way. And these are not the only 2 at all, but these are just a couple of common examples. Hodgkin's lymphoma is a type of cancer. It's cancer that affects the B cells. So it's going to affect antibody production. And acquired immune deficiency syndrome, which we call AIDS, it impairs the functions of, especially, it affects the T cells, but especially the helper T cells. And then immune diseases, autoimmune diseases. So auto refers to self, and these diseases occur when the immune system loses its ability to distinguish self from non-self. And that can be really dangerous because as a result, your body is going to produce antibodies or cytotoxic T cells that will attack your own cells and tissues. So basically your immune system is attacking your own body. This happens with multiple sclerosis, where your body actually destroys the myelin that covers certain neurons of the central nervous system. This is also what happens with type 1 diabetes, where immune cells destroy the pancreatic cells that produce insulin. And another common example is with rheumatoid arthritis. This is where the immune cells are destroying the body's joints. Okay, so that brings us to the end of that immune system outline. So now you guys have everything that is not in the recorded lectures. I really encourage you to make sure that you're watching those so that you can fill in any of the other gaps that are left in these study outlines. As long as you do that, you're going to have all the information that you need to prepare for the next test. So you guys only have 2 more left, Unit 6 and Unit 7. So that's it for today. I'll post announcements in Blackboard, or not Blackboard, D2L, just reminding you that I'm going to meet with Lab Group B on Tuesday. All right.
Question. Laura, for the test, do you drop the lowest grade?
If you take the final exam.
Oh, okay. All right. Okay. Thank you.
As long as you take the final, then that will replace your lowest grade.
Gotcha. All righty.
Okay.
Have a good one.
Yeah, you too. All right. Bye, guys. Have a good day.
Bye. Have a good day.
Thank you.